welcome to everyone. Good evening, and thank you all so much for joining us tonight. This is quite exciting because this is the first in HCSA's wellbeing programme. This is the first webinar that we're having. My name's Joanne Findlay. I'm HCSA Policy and Campaigns Officer, so I'll just be facilitating tonight. And obviously we're HCSA, the Hospital Doctors Union. We are joined by the Association of Anaesthetists, who are delivering tonight's webinar on an extremely important topic on fatigue. So we have Dr. Emma Plunkett and Dr. Nancy Redfern as our fantastic guest speakers. And Emma and Nancy are both consultant anaesthetists, and they're also co-chairs of the National Joint Working Group on Fatigue. So we're really very lucky to have such experts in their fields with us tonight. And I will pass over to them in just a minute when they'll tell us a bit about their campaign, Fight Fatigue, and they'll really sort of explore what fatigue is and how it impacts our well-being and what we can do about it in the workplace. But before I do that, a couple of quick housekeeping things, pretty normal for Zoom, but just to let you know, we are recording tonight and it will be available afterwards for anyone that's missed it, and for you if you want to watch again later. We're asking everyone please to keep muted during tonight just to sort of minimise the disruption, but we would really like some interaction with questions if you have any. If so, please use the little Q&A tool down at the bottom. So you'll see the two speech bubbles with Q&A. And if you'd like to type your questions in there, we'll make sure we leave some time at the end to try and get through as many as possible. This is scheduled for an hour, so we'll try not to overrun. And if there's any extra questions, we can always answer them by email. The other thing just to point out, oh no, I've already said about recording. So yeah, that's it for the housekeeping. Fantastic. Over to Emma and Nancy now then.
Thanks so much. Thanks for having us. So I'm Emma. I work in Birmingham, as it says on the slide there. I've been a consultant for about 5 years, so I've it doesn't feel that long since I've kind of transitioned from the sort of trainee rotas to consultant working. And Nancy?
So I'm Nancy, and I'm rather at the other end of my career. So I've been a consultant since 1987.
And I've got control of the slides, so I'm going to advance slides on behalf of myself and Nancy. And I'll just make sure that's, oh, hold on. Yeah, there we go. And as Joanne was saying, we co-chair a joint fatigue working group, and we're going to talk a bit about what that is and the work that we've been doing. And we work as a kind of a partnership between the Association of Anaesthetists, the Royal College, the Faculty of Intensive Care Medicine, and then we have co-ops with sleep physicians from the Royal College of Nursing, from paediatrics, to kind of share their experience in the work. And we often talk on this subject, and we just wanted to kind of acknowledge that some of the slides, it's a sort of collaborative approach, so a collective brain approach to kind of presenting. So this is what we're going to cover. Hopefully the purpose of this webinar is to increase the awareness of fatigue, and you'll understand it a little bit better at the end of the hour. We're going to talk about sleep physiology and sleep hygiene, some of which is stuff you already probably know and may or may not put into practice, but perhaps you'll kind of understand a little bit more about kind of why it's important. We're going to talk about how it affects performance, how it affects kind of how we learn, and then importantly to think about the things that we can do to kind of manage fatigue and to mitigate the impact of fatigue. And we'll kind of refer to our Fight Fatigue campaign that the HCSA have also recently, I think, signed up to back, and kind of how we've approached to kind of changing culture. So we're going to have a sort of conversation really, and I'll talk for a bit, Nancy will talk for a bit, and then at the end obviously we'll both kind of be available to answer questions. So Nancy, I think you were going to start by kind of talking about how we started.
So the word started for me, I'm sorry, I've got a bit of a sore throat, so I hope you can hear. I was just sitting on a coach talking to the then chair of the national chair of the trainees in anaesthesia, asked him what sort of week he'd has you do. And tragically, he'd spoken at his colleague's funeral. He's a lovely chap. He'd done 3 night shifts. There was a bed to sleep in, but he just wanted to go home because his wife was 7.5 months pregnant. So he wound the window down, put his phone on loudspeaking, and was singing to his wife when this happened. So that was a personal tragedy. But I was the membership secretary at the Association of Anaesthetists at the time. Something had to be done. This to me was a tragic and unnecessary loss of life. And then as we started to read around it a bit more, Ronnie wasn't the only person who died driving home. Lauren Connolly, who I think is on next, she'd done 3 night shifts as a foundation doctor. And then when we read more, there were nurses. These are other doctors. This chap had just moved house and had got a 4-month-old baby. The next one ran into a dustbin lorry driving at 50 miles an hour on his way home. And then here's another nurse. And very tragically, we've just recently had another death. So it was obvious that, you know, were these just one-off things, or was this really the tip of the iceberg? And do you remember, Emma, how you were then a trainee chair, and how we kind of started to think, well, we must do something about this?
Yeah, so I took over from Ben Denai as chair of the trainee committee, and actually it was a group of trainees in Wales who had started a survey of Welsh trainees about fatigue, about commuting distances, about accidents, because there's lots of anecdotes, some of it obviously reported in the kind of papers, the really kind of horrible tragedies that happen, but we wanted to start collecting some actual evidence around this, something a little bit more robust. So we took their pilot survey and spread it kind of nationally, and we got a really impressive response rate for a survey. At the time, we had trainees responding from, I think, every hospital in the UK. And this is just kind of the headline data, really, that 57% admitted to an accident or a near miss post-night. So these are the people who feel comfortable enough to kind of mention this. As trainees, they often are in large geographical areas, so large numbers are commuting for more than half an hour, and most commute by car or motorbike. It's those people in London, I think, who tend to use public transport. And 84% had said in this survey, so this was done December 2016, so it's a good few years ago now, but was saying that they felt too tired to drive. Access to rest facilities wasn't great, and actually these were on-shift rest facilities, and they're kind of sleep-off facilities to use at the end of a shift. They were much less available. Actually, it was around sort of 30%. And people felt that fatigue was adversely affecting their health, their psychological well-being, and their relationships. So we presented this data and we wrote it up, and it was published in the journal Anaesthesia. And as we were talking about it, obviously the consultants and other grades of staff were thinking that actually this affects everybody too. So we also then went on to survey consultants. So this was done, I think, 2018. And 91% of consultants who responded, and again, it was over 4,000 responses, so decent numbers, said that they had experienced work-related fatigue. So it's pretty much unanimous. And I know you could argue that probably whatever job you do, there's an element of fatigue, but as kind of healthcare professionals, we work in a 24-hour system. So we are often working when, as we'll talk a little bit about later, you know, our physiology would suggest that actually we should be resting. A good number reported a car accident or a near miss post-nights. Most of these were as trainee doctors, but still 1 in 10 as consultants. Again, people commute by driving, and 60%, so well over half, are feeling that they're too tired to drive. Access to rest facilities was poor for consultants. And then the data around how people perceive the impact of fatigue was those people who said that fatigue had a moderate or severe negative impact on their health, their well-being, and their personal relationships and family. And we asked questions about sort of the potential causes of fatigue. A lot of it was around staffing, lack of access to breaks, about the kind of non-clinical workload and having to cover gaps in consultant rotas, or as we still seem to be getting quite a lot of them at the moment, gaps on trainee rotas. And there's a little bit of data from other kind of medical professions as well. This is not a kind of isolated phenomenon that is unique to anaesthetists. I know there's been some work in emergency medicine as well. So I think this kind of helped kind of collect and turn those anecdotes into a bit of evidence that actually, you know, fatigue is widely experienced. It's a normal part of our work, and we really are not managing it as well as we might do. So Nancy, we were starting to think about change then. So
yeah, so if we look at the next slide, it was really hard. You know, this is something that's just been going on forever, and how are we going to manage change? We've all got 101 ideas and little concerns going on in the back of our brains. But what's said is you only actually put the effort into doing something when you get a sense of urgency. And of course, that sense of urgency came for me with Ronnie's death. And then what we do is we look for remedies. We realise that some remedies, some possible solutions have disadvantages as well as advantages. Weigh up the choices that we have available to us. And the decision to act isn't just logical, it's also emotional. And I think because we've done the survey of both trainees and consultants, and particularly from the start, from the trainee survey, that kind of emotional, we must do something, was really quite powerful amongst the trainees. Next one. So what really I think we were looking at was there's a lot of stuff out there that we just hadn't really realised until we started looking at this. What happens to us as doctors looking after patients is that after about 12 hours, our empathy starts to wear thin, and I'm sure we've seen that with some sort of rather monosyllabic exchanges in the middle of the night. Then after about 15 or 16 hours, that logical reasoning of having to do a calculation for a dose for a child or something becomes really, really difficult. Vigilance, which of course is really important in anaesthetics, but is very important everywhere, really, becomes much more variable. And the intellectual flexibility we need when we're managing a fast-changing situation goes down. Psychomotor skills get worse, and there's a lot of this in different bits of surgery, but also I think in people who do any practical skills like putting lines and drips in. And our ability to learn and retain information gets worse. Our mood gets worse, so of course our teamwork suffers. So really, everything that has to do with looking after patients just gets worse. But the other side of this is that night shift work affects us. As well as being more prone to accidents and incidents, the amount of diabetes, hypertension, strokes, heart attacks, there's really good evidence for breast, bowel, and prostate cancer, but there's more evidence coming on board for other cancers. And I've got peptic ulceration, but to be honest, the top 10 most common diseases are all most common in night shift workers. So we've really got something that is going on that is having negative effects on our patients and negative effects on us as well. Next slide. One of the things about this, though, is we're not very good at realising. If you look at the graphs with the black filled in squares, then when you do physiological testing, which is on the left, the tests show that we're pretty poor when we haven't had any sleep at all, and that's what the black squares are. And when we self-assess, when we've had no sleep at all, we think fairly similarly. But if you look at the graphs with the round open circles and with the round open squares, round open circles is 4 hours sleep and round open squares is 6 hours sleep. Physiological testing shows we're not actually much good, but we score ourselves as being all right. So we really don't grasp how much the sleep deprivation of only having 4 or 6 hours is affecting our performance. Next one. So we decided we needed to look for some remedies. One of the things was to get some teaching resources, and we did all these posters, which if you search Fight Fatigue, and we'll put a link at the end, you can get. Next one. So we also got quite a lot of educational material, which, you know, I think has been really useful in teaching. So, Emma, were you going to say something about teaching?
Yeah, that's right. I was going to have a quick run through the sorts of things that we cover in. So I talk to our junior doctors now. I talk as part of the and levels about the sorts of things that we need to know. So I thought we'd just cover some of the kind of science around sleep and fatigue. Actually, just as a reminder, I think some of it you'll know already, but actually just go through the sorts of things that we cover really. So what impacts on our level of fatigue? So I think it comes down to sort of these three things broadly: how long we've been awake for, how long we've been asleep, how long we've been awake, and the time of day. And I often ask when I'm in a room about this, how often people get, obviously working patterns aside, how often you get 7 to 8 hours of sleep a night. If you've read the book by Matthew Walker, Why We Sleep, I think he says that you're more likely to be struck by lightning than you are somebody who actually can manage on less than 7 to 8 hours of sleep. But actually what happens is you lose insight into kind of how fatigued you are and sleep deprived you are. And as you it's quite easy then, if you're having kind of 6 hours sleep a night regularly, to accumulate this idea of a sleep debt. And this, as Nancy has just gone through, will affect your kind of performance at work and actually has impacts on your health. So unless you are somebody who doesn't work shifts at all and absolutely has perfect sleep, there is probably, you're probably already slightly sleep deprived. And actually I was worked yesterday and then on call last night, so I think I am a little, although I have had a nap this afternoon. So then what about the time awake? So actually there's been a lot of work done on this, and once you've been awake for 14 hours continuously, your alertness is significantly reduced, and once it gets over 20-21 hours, then actually your performance is impacted in a similar level to basically you being over the legal limit to drive alcohol wise. There've been studies done on accident risk with length of shift, and after an 8-hour shift, then the rate of accidents, these are kind of industrial accidents, increases exponentially. And obviously we do a lot of 12-hour shifts, we do a lot of long days. Our consultant fatigue survey actually asks questions around the kind of out of hours working. It's quite common for us to do that, and I think we like that idea, so we can get compensatory time off. The kind of risk is then you've got days off, and the temptation is there's plenty of work out there, so often, you know, to kind of sign up for those requests for extra work. So yeah, I've said the impact of fatigue on performance. And then obviously we have this circadian rhythm, which we will all have experienced kind of throughout our kind of working lives and our training. And actually, obviously, you have that circadian dip in the afternoon, and actually a peak in awakeness around this time of day. So hopefully, actually, you're all kind of feeling reasonably awake. But this dip comes in the early hours of the morning, 2 o'clock in the morning to 4 o'clock in the morning, in particular, when it's very, very, very hard not to feel tired. Mike Farquhar always says his sleep physician is part of our group. You know, working at night is like working when you're very, very jet lagged, and you wouldn't go on a flight to another time zone and just immediately be expected to kind of get on with work, or you shouldn't at least. So just this, this is taken from one of our fact sheets actually. So I've said a lot of this already, and I think it kind of highlights the kind of impact. So if you're doing long hours or shifts and then you're getting in your car to drive home the next day, at the end of the shift, you're really at risk. I just wanted to mention a little bit about kind of micro sleeps, which is probably what happened to Ronnie, which is a kind of unexpected kind of short sleep for, it can be kind of up to several seconds. And there was a really interesting BBC Inside Out article where they took a doctor who'd just done some night shifts on intensive care and put her in a driving simulator and kind of looked at the kind of number of lane violations and micro sleeps, and it was kind of, it really made you realize just kind of the impact of fatigue. And it doesn't get better. You don't need less sleep as you get older, unfortunately. You just sleep worse. So, you have more interrupted sleep for various reasons, so actually it's not that you need less sleep, you need the same amount of sleep. Things you can do, this is to kind of look after your core sleep. So this, arguably is the bit of sleep that we have control over, because this is our kind of non-shift based work. Limit your blue light exposure in the evening. So actually I have some of these anti-blue light glasses that I put on if I'm on my laptop or looking at my phone later in the evening. So from sort of 9 o'clock onwards, to try and limit my blue light, because blue light reduces your melatonin levels. So it reduces the quality and quantity of your sleep. Ideally you don't have your phone in your bedroom, you use an alarm clock instead. Make sure your room is really dark and kind of unchallenge your brain, so make sure dark and quiet, and that your room is cool but your bed is warm. There is some actual data that a hot bath or shower, and it's kind of actually physiological, is good before bed. As you get out, you vasodilate and your body temperature just drops very slightly, and this kind of makes it easier to fall asleep. And then there's that whole idea, you know, often you get into bed and you can start thinking of all the things that you haven't done, but actually it's about how you manage that kind of mental workload. You know, make a list, and there are lots of kind of good apps. I use a lot of Headspace, but obviously there are other apps available to kind of just unchallenge your brain and kind of switch off. And then you need to kind of know yourself and have a little bit of a think about whether you are getting optimum sleep. They say that when you go on holiday, you should, for the first couple of days, stop setting an alarm so you can catch up on sleep, and then start to get to know whether you're someone who can manage with 7, or if you're more a sort of 8-9 hours sleep person, so you sort of know what you need. And yes, there are people who are better in the morning or the evening, and everyone is different, and sometimes it is difficult to sleep for 8 hours straight. So think about sleeping in a way that works for you, but you do need that kind of duration of sleep. And some people actually set up sort of you can get it now on your phone, can't you? The apps and the alarms for when it's kind of bedtime and time to kind of wind down. So yes, I think our message overall is about prioritizing sleep. What about shift working then, and how to manage shift working? So during a night shift, I know consultants nowadays don't do a lot of night shifts. I think most people do an on-call working pattern, so perhaps a long day and on-call overnight. But actually there is a move towards night shift working. I know some of our obstetricians work nights. My husband's a paediatric intensivist. He works a lot of out of hours. So this is all still relevant stuff. It's not good for you physiologically to eat overnight, but sometimes I recognise you do just need those kind of that boost of some kind of carbohydrates to kind of keep you going in the middle of the night. But just be mindful that actually if you're regularly doing night shifts, you should think about kind of eating healthily. A power nap in a night shift is absolutely vital, and Nancy will talk a little bit about that later on. And as I've mentioned earlier, just be mindful of that 4 o'clock dip, and particularly put into place practices to keep you as safe as possible with doing complex tasks at that point of the night shift. Think about if you're doing a run of night shifts, and this first bit about planning how you're going to get home, you need to do that before 8 o'clock in the morning when you're sleep deprived and you can no longer make rational decisions. If you drive to work, most likely you're going to drive home because that's what you've planned to do. Interestingly, it's been suggested about kind of limiting your kind of bright light exposure so you can get good quality sleep when you get home, but obviously you have to be safe about that. But make sure you eat before you go to bed, and then go to bed as soon as possible when you get home. I remember as a junior doctor, I used to sort of, I don't know, faff around a bit in the morning when you get home, and then it's kind of late morning, lunchtime before you go to sleep, but then you haven't got as much opportunity to sleep between night shifts. So we always highlight this to our the doctors. And then recovering after a night shift, the aim is to sleep, same again really, sleep early in the day, get up, get some natural light exposure, and try and go to bed at a normal time to try to sort of switch your circadian rhythm back as quickly as you can. And you will need at least 2 nights of normal, good quality sleep to recover from a sleep debt. So that's a kind of summary really of kind of the sorts of points that we pick up when we're trying to, and we've got a series of kind of fact sheets that kind of pick out those key points that that actually are part of the fatigue pack. So I think, Nancy, we're going to talk a little bit about the practical ways we've got these educational messages out there.
Yeah, so that's what Emma's just done is what we do when we're talking to our trainees. And the slides are all available, and Emma's a college tutor, and I mean I was doing this with the trainees from South Yorkshire earlier on this week, but that package is really helpful. Anyway, the other thing we did was Emma and Lauren drew up these lovely little fact sheets, and we've used them all over the place. This is us putting them, they're in the changing room, they're behind the loo door. It took us a little while to realise that some of the people weren't reading them, and so one of the chaps went into the gents and positioned them appropriately there. So that was one thing. But another business was that we hadn't really, there's no point in saying have a power nap unless you've got somewhere to actually nap. So we found out about beds, sofas that turn into beds, and this purple one, the ends come down and the back flips over to have a nice little holder for a cup of coffee and a phone and things. So they've been pretty popular. The more moneyed hospitals, some of them have got sleep pods, and this is being a sleep pod being demonstrated in Bristol. Our college asked us for some standards, and this is one of the 3 standards. There's one for organisational culture, one for individual responsibility, and this is the standard for what facilities there are available. And we're about to launch an audit tool whereby we hope all the trainees are going to audit what their department actually has at the moment, just to show a little bit more about how we're getting on. What we're trying to do, if you look at that bottom end of the graph, it's called Miller's triangle, and the bottom 2 are you just know something or you know how to do something, and that's just competence. But what we really want to do is change people's performance, their behaviour, so that their understanding of how to manage night shifts and how to manage their own sleep moves into just normal behaviour and becomes what we actually do. Next one, thanks. I feel like Chris Whitty saying this. Ridiculous, isn't it? The survey we did of the consultants, we had a really good editorial. One of our number, Kerry Sutherland, who's a very quiet and unassuming but absolutely brilliant sleep physician and anaesthetist who works in South Tees, and she knows everybody, I think, in chronobiology, and she said get Drew Dawson to write an editorial, and he wrote something that was really, really helpful. I think the next comment, and he says that the way the health service works, having more staff on the rota or better rotas with more breaks or compulsory rest periods, all these things that are used in all other safety critical industries, these tried and tested solutions, the likelihood of implementing them is close to 0 in the current NHS environment. And he suggests, I'm not sure if it's on this slide, but let's have a look. He suggests that we use a different sort of approach. And what he's saying is every other safety critical industry has a proper fatigue risk management strategy. So, I mean, I've done lots of national speaking, but I thought, well, it's a bit ridiculous, isn't it? If you're not doing something on your own ward. And then using the stuff Drew Dawson said, and what he says is in the health service, instead of looking for more staff, look more carefully at the sort of frequency and duration and intensity of the work. So make sure it's not going like the clappers the whole night. Make sure everybody gets their break. Make sure that the team has got some people who are more experienced, because the level of supervision and the support from the wider team makes a huge amounts more difference in that circadian nadir than do other things. But that your fatigue risk management system overall has got to have the predictive stuff, the proactive stuff, and the reactive stuff. So if we now move on, what we did was we got this. We were really lucky. We found this chap called Jason Eden at this place called SAFA, the Safety and Fatigue Research. And it wasn't anything to do with working in the health service, but it was very, very useful for us in our study on the labour ward. What it had was this the people wore a Fitbit on their ankles because they're below the elbows. And green was out for a lorry driver, you're all right to drive. The yellow was you'd be between 2 and 5 times more likely to crash. And the red was you'd be more than 5 times more likely to crash your lorry. And so you got these graphs, and the middle one shows you a prediction for the next 30 hours. But showing a senior, one of the trainees showed in the trial period, she showed a rather grumpy ITU nurse that she was in the red and said, look, please can I have a half-hour rest? Because if I do that, I'll be much more likely to write this patient's very complicated prescription properly. And for the first time in recorded history, the nurse didn't give her the full lecture on you're doing shift work, you're paid to be awake. And actually, when there's another little comment I think might come up next. So this was what a midwife found, that she realised that she wasn't getting the right amount of sleep between night shifts. And suddenly when she started to make sure she got 8 hours sleep between shifts, she said, by night 3, I was still half human. It was amazing. And we got these sofas that, as described, that turn into beds. Next one then. So the other thing we use is priming. When we have a night shift handing on to a day shift, we ask the trainee, whether, instead of saying, are you all right to drive home, when the message is, I'm okay to drive home, we actually ask them, have you had a power nap? And the idea of this, and it's in Daniel Kahneman's Thinking Fast and Slow, is that priming isn't under conscious control. The words you hear prime the thoughts and ideas that you have. And so what is said to us affects the way, the actions we take. And so by using priming and saying, have you had a power nap? Then we're trying to get people, to realise that having a power nap is a good thing, and to spot the people who haven't had a power nap. So, and then we've got to take control of it, because when you're too tired, your kind of amygdala takes over and you think, I just want to get out of this place. And the logic of go and have a half hour's rest and don't crash your car like Ronnie did is really difficult. And if you've got to walk a long way to find the place to have a nap, that's really difficult too. So we've got to help people there. So a little bit more about these power naps. Now, they came from some studies that I think were in the 70s and 80s, Dinges and I think Rosekind, and they were asked by the American Air Force. In the Vietnam War, they lost quite a lot of helicopter pilots from them having microsleeps and crashing their helicopter. And in fact, I think they lost more squaddies to these crashes than they did to the Viet Cong. So it was a pretty awful situation. And they asked these people, Dinges and Rosekind, to come and do some research. And what they found, they I think we're looking at a 40 or 50 minute nap, but they found that this short nap of 20 minutes it diminished the amount of times that people had these micro sleeps. So they made people much, much safer. So their recommendation was actually to have what they called a planned nap or a prophylactic nap. But then the pilot said, oh, we can't call it that. That's not macho enough for our culture. And that's why the idea of it being a power nap came in. And the idea is that you have a cup of coffee before you go for your nap, and then after about 20 minutes, the caffeine will take effect. Actually, I think if you're of a certain age, your bladder takes effect, and then you wake up again. So very much to be encouraged. Next slide then. And this is a study study done by somebody called Geiger Brown, Professor Geiger Brown, who was, she was a nurse by profession originally, and she did it in Wisconsin. And the first, the top half is a group of 6 separate teams where they measured the sort of influencing features that make a difference to whether you're awake or asleep. There's a homeostatic pressure to sleep. We release, all the time we're awake, release substances called somnogens. Adenosine's a somnogen, and caffeine's an adenosine blocker. That's how it works. And so as you go through the day, you're building up more and more of these substances. But against that, we have a circadian alerting signal, which keeps us awake until it goes dark, and then that just gives up. And you can see that the wake propensity goes down and down and down until you get to this circadian nadir in the middle of the night that Emma's talked about. Now, so she had her first group of 6 teams, and she also recruited 6 teams who were asked to make sure that they got a 30-minute power nap, not just 20, but 30-minute power nap in the middle of the night. And again, they did all these measurements. And if you look at that bottom graph, you can see the impact of that nap. And they felt safer driving home, but they were also more empathic to patients. And interestingly, and this is in nurses, they made fewer drug errors. So that the effect of the nap was really quite positive, even though it was a small amount. But the trouble she had was in recruiting the people, the teams that could have the nap, because there seemed to be some senior managers who felt that it was unprofessional to sleep when you were at work, even though it was actually safer for patients. And so because of all this, in 2017, the American Academy of Nursing changed their guidance so that a power nap is now recommended as part of the American Academy of Nurses approach to night shifts. Next one then. So that's kind of what some of the stuff we've done. And I think Emma's, just to talk a little bit more about how we've, the sort of challenges and successes we've had.
Yeah, that's right. Thanks, Nancy. I always learn something myself when I'm listening to you talk as well. So we just, I think one of the things we've sort of realised along the way, that this whole idea of sort of work as imagined versus work as done. So, you know, I suppose part of that is the idea that, you know, it's a shift working now and it's just 12 hours. So actually you should just be able to sort of crack on with it really, and actually who needs a break. But we know from all of the physiological data and the studies that that's just not the case. People need to sleep at night, and this idea of the people who aren't working the night shifts, that actually people are not sleeping at night. People, if there's opportunity, then people will take it, but just not in the most effective way. So, you know, you see the junior doctors with kind of just heads on the desk, kind of falling asleep. We need to be more realistic actually about our approach, so we really understand the kind of working environment for those who are actually working in the system, and our recommendations and our guidance kind of reflect that, not this kind of imaginary situation. So yeah, what have some of our successes been? Well, I think the first success that we've had was kind of, so we set these standards. So when we presented the trainee fatigue data, we wanted to have some kind of solution. So it's all very well presenting this kind of problem. We've defined a problem, but actually what are we going to do about it? And the education package for all staff, so it's not just for those working the shifts, it's also for those who support people working shifts, clinical and non-clinical staff. But the other thing was really about kind of setting the standards and getting them adopted. And these standards have now been adopted by the Royal College of Anaesthetists for their AXA accreditation program. So this is a voluntary accreditation program for departments, but it's a kind of marker of high standard, a high quality anaesthetic service, and these standards are part of it. They're also, fatigue is referenced in our kind of GPAS document, which is another kind of standard document for kind of anaesthetic departments. So actually having that recognition and adoption of the standards has been really kind of key. We've also had some success politically. Obviously, there has been masses else going on the political agenda. So this, has been kind of timely. But these are members of our fatigue group who've engaged with all parliaments in the UK. Particular success in the Scottish government, who've kind of adopted our kind of fatigue package as part of Scottish government policy. So it's really good to have that recognition, because this is something that we need to kind of engage individuals about. We need to engage, as I said, the kind of non-clinical leadership, the government. It needs to kind of come from everywhere to kind of really affect kind of culture change. And we were really lucky to win a kind of BMJ Team of the Year award in the wellbeing category for all of this work and kind of recognition of the stuff that we've been doing. We've also tried to track the data. So obviously trainees have to complete the GMC survey every year. So we've had questions in the anaesthetic, specialty specific questions about fatigue. So these have been for 3 years now, but obviously 2020 we missed because the survey was different for during the pandemic. So and we started to see a success. So but we still also recognise we've got a massive way to go with this. So over the last few years, access to education about fatigue or sleep has improved. It's been a bit static over the last couple of years. We also ask if people have found it useful, and that's been fairly consistent. So about 3/4 of the trainees who actually managed to attend the teaching find it useful. How often have you felt tired to get home safely? So this has reduced, which is a kind of trend, I think, in a positive direction, which hopefully reflects some of those conversations that people are having at the end of shifts, and perhaps that actually rest facilities are getting better and people are now managing to rest more on kind of night shifts. What about the support to take breaks, especially on night shifts? Now, this data is a little bit skewed by the fact for the first 2 years, it was for core trainees who were particularly well supported to get breaks. And then in 2021, it was just asked for specialty trainees. So although it looks like it's static, actually, there has been a slow kind of improvement to get breaks. And then what about impact on fatigue on progress through training? So actually this is also showing a trend to improvement. So obviously still lots of work to do, but I think hopefully some signs that we are slowly managing to kind of change the culture.
Okay, so I think we'll draw that to a close then. I think if we were in life, you'd be getting a really roaring round of applause right now. But unfortunately, Zoom isn't the best for that. But I do want to say thank you so much, Emma and Nancy. It has been so informative, really, really eye-opening for me. And I know others have felt the same, especially judging by the engagement in the chat. So thank you very much for that. Thanks also to everyone for joining us today. It's really appreciated you coming along. I have stuck in the chat our feedback form. As this was the first one in the series of webinars, it would be really useful if you could fill it in kind of right now before you forget. That would be amazing. And we'll of course pass all the feedback on to Nancy and Emma as well. So yeah, please do fill that in. Also, we will be running more of these. The next one's on bullying, so we'll put out some information about that in a registration form, and it would be really fantastic to see you there as well. So yeah, thanks everyone, and have a really good night.